This conference will now be recorded.
It's Tuesday, August 25th, 2026. Welcome to the AnCan virtual support meeting for high-risk, recurrent, and advanced prostate cancer. It's good to see everybody here. Thank you all for joining. I'm moderator Ben Nathanson, and I'm joined right now just by Rick Davis, the founder of AnCan. We expect Len Sierra and John Antonucci to join later. You'll hear medical issues discussed, but we're just a bunch of guys. And nothing you hear is to be taken as medical advice. We're grateful to our sponsors, Novartis, Telix, Blue Earth Diagnostics, and Foundation Medicine. They help underwrite this call. We thank them. So we'll begin. We have new participants tonight, and conversations with newcomers lead off our meetings. Our first is Bill Mullen, who, as Rick said, is kind enough to pre-answer some of the questions, which saves a great deal of time. And I will just go through them so that everyone in the call will be up to speed on Bill's case. Bill is 70. He lives in Rumson, Jersey, near the Jersey Shore. He heard of AnCan on a support call with Jim Marshall, who introduced him to the group. Bill was diagnosed in November 2025. At the time, his doctor was Dr. Ali of Urology Associates in Shrewsbury, New Jersey. That's where his biopsy was done. That first biopsy showed a Gleason score of 6, but he had rising PSA scores, which prompted a second biopsy in June, and that Gleason score was 8. And he had a PSMA PET scan in July. It showed that the cancer had spread to a few different sites in his pelvic area. He's now being treated by Dr. Karen Autio, a medical oncologist at Memorial Sloan Kettering in New York City. So the biopsy had 12 samples. 1 was Gleason 6, 1 was Gleason 7, and 2 were Gleason 8. Bill had gotten, after the Gleason 6 diagnosis, he had decided on active monitoring, and he'd gotten a second opinion at a local MSK office from Dr. Robert Smith before deciding on active surveillance. After the Gleason 8 diagnosis, he started on hormone therapy, 1 shot of degarelix, followed by a shot of Lupron and Nubeqa. He had, before each biopsy, an MRI, and after the second biopsy, a PSMA PET scan. In the last month, he had a bone scan, which confirmed the PET scan, and a bone density test that indicated osteoporosis in the left femoral neck and osteopenia in the left hip. So aside from the degarelix, the Lupron, the Nubeqa, he's on blood thinners. He takes Xarelto, 10 milligrams, due to predisposition for blood clots, which limits Bill's eligibility for clinical trials. He has not done genomic testing yet, but is talking about it with Dr. Autio. And there were a few questions, additional questions. Hang on. We got lots of questions. Okay, Rick, these questions were yours. I think some of them at least are answered. What led to the second biopsy? That's answered. Where and how many metastatic locations are there? That's been answered. Were there
not how many metastatic locations, and I guess I was wondering, was it just it was the rising PSA score, but what was that rising PSA score? How high did it get, Bill? How high did it get before it drove you back in for that second biopsy?
So before the first biopsy, my PSA was 4.8, I believe. And when we went on active surveillance, continued to do PSAs, I think actually it did a total of 4 or 5 in those intervening 6 months. I was doing pretty regularly. And it rose kind of every time I did another PSA, it rose another couple of points. So it went to 7, then to 9, and to 11, 13. And the last one that I had taken right before the second biopsy was 15.8. That was the last one.
Okay.
Since I've been on the hormone therapy, we did another PSA, and that was 2.6.
And how long after the start of the hormone therapy was that?
That was done a month after the Gerolix shot, taken at the same time as the Lupron shot. So it was a month into hormone therapy.
It was a month in, and what month was? I'm just looking. What month was that? You know better than I do. You can.
Yeah, that was earlier this month.
Okay.
I believe the 14th. I believe.
Okay. So, and then the other question I had was, it said you had a few different sites in your pelvic area. Tell us a little more about where these sites were seen.
Yeah, so I don't know if I have exact locations, but I will pose something which I've told my doctor a bit and I need to pursue more, and it's a little puzzling how to take any input you guys have. So what happened was when I had the PSMA and I met with my urologist just to, read the report, and he said, yeah, it's spread to your pelvic area. Okay. So at that point, I'd already decided I was going to go in to MSK in New York and deal with an oncologist there. Then in MSK, they read the same PSMA scan and initially told me it was not only in the pelvic area, it was in 3 other areas: rib, scapula, and femur. But she said those additional areas were not as bright red as the pelvic area. And I believe there's a total of 5 lesions in the pelvic area. So what they did was a bone scan, which we then talked about that, and my doctor said the bone scan indicated to her that those indeterminate remote areas were not probably tumors.
Okay.
And that kind of swayed her to say, okay, we're going to start with just doublet as opposed to triplet therapy for now.
Yep.
And she said that was all based upon volume of tumors.
Right.
And with the reading from the bone scan, felt like, okay, we were okay with doing that and with holding off on chemotherapy for the time being.
Right. And in that pelvic area, was it in bone in the pelvic area, or was it in the lymph nodes?
Yes, everything is bone.
Oh, everything's bone. Okay.
Yes, everything is bone. Yeah.
And do you know how many sites they saw in?
I believe I had 5 lesions in the pelvic area.
5X. Okay. Well, I think we can trust her, but I'm going to have to ask Mr. Fish, because he's only been with Dr. Audio for how many years, Mr. Fish?
I guess 7 going on 8.
Oh, super. I'm glad to hear that.
Well, I'm glad too, for the time being. What is it I'm supposed to say? We have a very good relationship. I trust her. She is pretty protocol oriented. She doesn't like to experiment much, but if I demand something, she goes along. We discuss everything. I discuss all the concerns questions I have because of this group. She expresses her opinion, and we come to a decision about what we're going to do. And then we follow up with that. Mostly, I'm deferring to her. She's quite knowledgeable. And she understands when we talk about Claude, what she does, what Claude says. They're sort of getting in that direction, but they're not really too strong yet. It's still, as she says, well, I agree, it's still a bit of a science and there's a bit of art involved. It's like,
Yep.
It's hard to say. It depends on the person. I found the ability to tolerate everything, and therefore we agreed not to change anything, although I know there's risk in not doing that.
Yep. Yeah. I mean, I'm very happy with my short term that I've been with her as well. I would say just from my own research, one of the questions I have is, you can see some doctors are more aggressive with using chemotherapy up front, and trying to overlay that. Again, I'm going to rely on what Dr. Audio tells me to do, but I'd just be interested if there's any opinions as to whether people think that's an effective approach.
When I talk to her about people who may be in this group or elsewhere who see her, she says, she's not going to discuss her patients with me and hopes I refer them to a professional like her and not try to diagnose or give them medical advice. But what can I say? I have a good relationship with her, and it's more important than sometimes some of the specific choices we make.
Yeah, understood.
It's risky all along the way. None of us have cures. I don't know. I don't really want to answer specific questions about treatment and diagnosis unless it's about me.
Yeah, I agree with you 100%. I was just wondering if anybody had gone through that.
Yeah, I've been through some bad doctors. I've been to Dana-Farber. I mean, I've gone to really, like some of the top experts, and they thought what I'm doing is reasonable. I came back to Sloan, and that's where I am. I think it's important to be with a medical oncologist, someone who does research, someone who's on the top of her game or his game, and I don't know. Nobody knows.
So, Ben, I have an answer for Bill, but what answer? What are your thoughts on eligibility for chemotherapy at the outset with three possible lesions, but really not at all sure, and 5 lesions in the pelvis?
If they're willing to accept the bone scan as a tiebreaker, it sounds sound to me to defer the chemo.
Is there a downside to doing the chemo up front? I'm just so. I'm sorry. I'm new to a lot of this, so.
No, it's good. It's a very good question.
Horrible
question, Bill.
I mean, let's assume that I can tolerate the symptom part, okay? In terms of long-term health outcome, that's what I'm more interested in. Is the
right. Well, look, I think the long-term health outcome is that if you have more than 5 lesions or more, 4 or 5 lesions or more, because some people say it's 4, some people say it's 5, we don't really know. But if you have multiple lesions, you're better off doing the docetaxel up front. Question is, we don't know if you have multiple lesions because 4 or 5 is right on the margin, and they're all roughly in the same area, which is significant. RJ, you had to face this doublet versus triplet. What were your thoughts on it?
Yeah, my thoughts are that it's kind of borderline. So this gets into what Larry's saying about the art. And it's also like being informed. So I think you're right in that, well, if I want to be more aggressive, then is it something I can do? And that was my thinking. And I actually had 5-ish lesions. I had one on my rib, so the other ones were in my pelvic region, right? So like my pubic bone, my sacrum, a couple more on my pelvis. And so what I did is I went ahead with the triplet, and I will say that it is no joke. And one of the things as you're kind of researching and asking questions is that I don't have any permanent side effects other than the experience, which lasted, probably 3, 4, 5 months after I finished the chemo. And my main thing was, I mean, I had proctitis during the chemo itself, but that was brought on by radiation. So I had radiation first. So, and I was on the doublet, and then I did radiation, then I started the chemo. And and I talked to my medical oncologist, and he kind of advised against it as well. And I said, but, like, what if there are, these different types of cancer? And he said, yeah, like that's what when you have a high volume, it's more likely that you will have, I mean, it's very heterogeneous, right? The cancer, and it's doing its own thing. But if you have certain types of cancer that respond to the chemo, then that's a good thing. If you have low volume, you're less likely to have that. So what they're advising against, and it's kind of like this do no harm thing, is that, well, you're going to do harm to yourself by doing the chemo. Like certainly just going through chemo, that is an experience. And then some people have permanent side effects, particularly neuropathy, right? They lose the feeling in some of their fingers or some of their toes, and that becomes an issue, and I mean, it's not a huge thing, but it is a thing that you just have to live with, and over time it gets better. I would say during chemo I had the neuropathy and it went away, but they're just advising against putting yourself through that and potentially the risk of these side effects for questionable gain. So it's just one of those borderline things where, and I did it. I was very well informed about it. I would do it again, but it was no joke.
Okay, very good.
Rick?
I mean, and tell me if I need to stop.
Go ahead.
But at this point, well, when I first got diagnosed with it, Gleason 8 and the spread, and we thought it spread to like lots of areas, I was like, all right, I just got to go get my will done, and it's coming quick. And then I guess I learned more, and plus the fact that it may not be all those areas. Okay, maybe I've got more time, but so that to me, it's all around. Just can I postpone the inevitable? And whatever I have to go through to get there. Unless of course my quality of life is just completely crap.
Right.
Whatever I have to do to get there. That's probably something I at least need to consider.
So I was just checking. I think you said that you're now on an ADT drug plus Nubec. Yes, Nubec.
Yes.
So I've got a couple of suggestions for you to discuss with Dr. Audio. First of all, the general experience here, if you can get on it, is that Orgovyx, which is the daily pill, is a better drug than Lupron.
And say that again. What's the name of it again?
Orgovyx. I'll put it in the chat window for
Super.
you. Did anybody tell you where the chat window is, or have you figured it out?
Yeah, I can see it.
Okay. So Orgovyx is a daily drug. A lot of the guys are now on it. It's a more recent drug. And we seem to feel that in many ways it's a better drug. If at some point in the future you can get off of the hormone therapy, you can take a vacation or a break, your testosterone is likely to come back more quickly. That's been our experience.
Okay.
And as a daily pill, it's easier to deal with than getting regular shots. So that's the first thing, and you'll have to see how much it would cost you. But the guys will, if you want to drill down on that, if not today, next time, the guys will talk to you about Orgovyx.
I
The
think
second
being
thing-
on blood thinners I think that was a factor in terms of what drug she decided to put me on.
I think it probably relates to the Nubeqa, but
Okay.
I don't know that it relates to the Orgovyx. I mean, we've been looking at that just recently. Any knowledge here as to whether cardiovascular situations are compromised with the Orgovyx? I don't
Not that
think
I know of, but Dr. John is looking into that one for the Orgovyx.
Okay.
I know.
And I think, Bill, I think we mentioned to you that we do have a heart group. Are you aware of that? Did somebody? I think I signed you up for it, to be honest, when I saw this, but I'll check anyway.
Okay.
We have a heart group in two formats. One, we have a email distribution that goes around to all of our prostate guys who have signed up for the heart group. And that tends to be more prostate focused. And then we are just starting a regular support group for cardiovascular issues for men, for women, people with any condition, just regular support. And that's hopefully going to get underway next week. There's been a couple of meetings of the prostate guys, but we're opening it up to everybody and welcoming everybody in that. So we'll make sure that you get signed up for that as well. If you're not already, I think you are, but check. The other thing that was on my mind to mention to you, and it's a little early yet, but it's something that you can put in the back of your mind, is that another treatment early on that gets discussed with men who are de novo metastatic like you are, meaning you are metastatic at diagnosis, is radiation to the prostate. It's not something that used to be done. It is something now, it's becoming more and more common. It's somewhat controversial. It doesn't have to be radiation. It could be surgery. It's what we call debulking the prostate, or taking the primary tumor out of the prostate. And we think it makes a difference. Ben, would you say a few words on debulking the prostate, or anybody else?
You're muted, Ben.
This conference will now be recorded.
But you're still muted. Yeah,
I'm
still muted.
Now you're not. Now you're not.
So yeah, the recording button here is exactly where the mute button is on Zoom, as moderators would know. Yes, there have been some recent papers actually looking at this, but I have not read them yet. So I would pass that on to something else,
Okay.
someone else rather.
Go ahead, Jimmy. You have hands up.
Okay.
Ben, you have hands up.
What are you doing about the osteoporosis? Do they have you on calcium?
Yeah, I'm taking calcium and vitamin D supplements.
3, right. Okay.
They are going to treat me for that. I don't remember the name of the drug, probably in November.
Okay.
The drug is probably Xgeva. Does that ring a bell? Denosumab?
Yeah, it doesn't, but they may not have actually told me what it was, but I
Okay. So
Another question, Bill. Do you have heart issues because of the blood thinner?
No, I'm on the blood thinner because I had a blood clot in 2020,
Oh,
and then
okay.
I got tested for the leading 5, DNA test, and said I had a predisposition to blood clots. I haven't
Okay.
had one since then.
And did you get the EKG done along the way just to see your QTC and QT and QTC intervals
I
offhand?
don't know what those are. I mean, I've had many ETGs over the last few years, precursor surgery,
Oh,
things like
okay.
that.
So
So,
they must have been okay.
yeah,
Otherwise, it
yeah,
would say abnormal. Okay,
yeah,
I'm done.
they all come back normal.
RJ, you have your hand up.
Jack, you mean?
Yeah, Bill. So I didn't catch whether or not you've talked to a radiation oncologist.
No, I mean, I only talked to Dr. Audio at this point in terms of oncologist, and I believe her thinking was that if this was, when we were discovering whether or not it had spread beyond the pelvic area, her thinking was that limited to the pelvic area, there's a potential to do radiation somewhere down the road. I think she wanted to see how the hormone therapy plays out, but potentially we could do, spot radiation, but we haven't decided
Yeah,
yet.
that's something that you might, to Rick's point, that you might want to discuss with her a little bit more in depth and do a little bit more research. There is the debulking of the prostate, which is a thing in de novo metastatic. And so I had that done. But also because your tumors are in your pelvis, one of the things that they can do with the tumors is there's a very precise form of radiation called SBRT. There's a couple different brand names, but one is
Yeah,
Cyberknife.
right.
Is that they can go in and they can ablate those tumors. And I would say at the same time that they do that, a lot of times what they will do is just kind of flood the zone. So they do a combination of IMRT and SBRT because this is cancer that right now is mostly contained to, not 100% necessarily contained to your pelvic region, but the vast majority of the cancer is there. So one of the things, in addition to a systemic therapy, is that they can, treat that particular area, and the way to treat that is with radiation.
And are you suggesting not to wait? Because again, we talked about what we were going to discuss again in a few months. Are you suggesting to try to move that up?
Well, one thing is to ask, why wait?
Yeah.
And then you'll get an answer, right? And then
Yeah,
you'll be more
sure.
informed. Yeah.
Okay. Very good. Thank you.
I would not feel bad about foregoing docetaxel. My thinking is that since the Mets are all clustered, they're probably all from the same clone. They're probably monoclonal. So there's not. I would guess that the diversity is limited. The other thing is that because there are relatively few, I my guess is that you could pivot fairly quickly. If you have a lot of Mets, you don't want to waste any time because it will overtake you really swiftly. But if you have a smallish number of Mets, I think you have a little time to see what happens um, and course correct. So if it were I would decline the docetaxel and not feel I was risking my health in doing so.
Okay, very good.
Also, the moderators, the people at AnCan all have different preferences. You could certainly ask about Orgovyx. You could ask about debulking, but I would not feel, crestfallen if the doctor declined one or both of them. Orgovyx in particular, I know Rick is a great enthusiast. It's you need to understand that some changes are more consequential than others, and I think that's a tweak, an optimization, rather than something that's really consequential for your care.
Got it. Okay. Super.
Any more questions, Bill, or any more questions for Bill?
Yeah, this is Paul. I'd like to ask how the MSKCC doctors now are approaching the Pluvicto 4 trial, which is the ability to obtain Pluvicto at the time of newly diagnosed metastatic disease. I'd be interested, Bill, if just in your questioning, to see where that playing field is developing in their mindset.
So we discussed it very briefly because it had just recently been approved, and
Right.
I do have someone in another support group who I believe is going to Mayo Clinic and getting that treatment. And in fact, we just haven't hooked up. I'm trying to talk to him live. He's actually was out there last week, I think for round 2 or 3. He's got metastatic and been dealing with it for I think a decade plus. And secondhand, I've heard that it's done a lot of good. That they were even not going to do additional rounds of Pluvicto because it had such a beneficial effect. So we only I didn't have that information in my last discussion with the doctor. Given that information, I'm going to be more aggressive next time talking about is that an option and when might that option get on the table.
Good. Yeah, good point, Paul. Julian?
Have you had your testosterone level checked?
Yes, it's low. I have to go back and look to remember the number. Between that and the PSA, Dr. Orty was happy with, we had it. It was achieving. My body was responding to it. I can't remember 40 maybe. I can't remember the exact number.
It was a low number, right?
Yeah, it was a low number. Yeah.
Okay.
Yeah.
Did you get a baseline testosterone before
No.
you started?
No. I mean,
Yeah.
that probably would have been good. Well, all I could tell the doctor was, I said, listen, she's like, trying to get a sense for, did I have low testosterone before? I said, listen, I have a fairly strong sex drive, okay? My wife and I are both in our 70s. We still have an active sex life, And she kind of took that as a good enough indication, given we had done a test of, okay, realized it wasn't just low before. So very qualitative, but,
Yeah,
that's as far as we got it.
as much as we talk to the doctors and we give this advice, they are reluctant to do baseline testosterone. I don't know why, but they are. If we would have talked to you before you started, we would have said, get a baseline testosterone.
Yeah.
It doesn't matter to them, but it matters to you if you can get a holiday, and it might not be for a while, but it will matter to you when you come back.
Yeah, understood.
So yeah, I think now I was going to ask you something else and I forgot what I was going to ask you. So
answer your question. Yeah, I'm probably not a candidate for the heart group because it's only blood clots, I think.
Yes, if it's only blood clot. I know what I was going to say to you. I do. The PSMA4, whilst it does technically make you eligible for de novo metastatic synchronous prostate cancer, it wasn't really tested in that environment from what I can recall. And I may be wrong, Dr. Paul, so please correct me. It was really looking more at people doing hormone-sensitive people who had not yet had chemotherapy being eligible. I don't know what percentage of PSMA4 were de novo metastatic. Do you recall that, Ben?
No, but that's something I certainly want to nail down.
Yeah.
So
and
help me out with what PSMA4 is.
Okay, PSMA4 was a trial for Pluvicto.
Okay.
And that's what just got approved that we're talking about here, which made it which made hormone-sensitive men with metastatic disease eligible to get Pluvicto. But I don't know to what extent it was examined as the initial treatment.
Okay, I see.
And we'll look, because now we're interested. Isn't that right? Isn't that right, Mr. Nathanson? Now we want to know.
Oh, totally.
And Dr. Paul's point is a very good one, but to date, we haven't heard of anybody getting it that early in the process. Like we would give triplet therapy, being two types of hormone therapy and chemotherapy. We haven't had anybody talking about triplet therapy, two types of hormone therapy, and Pluvicto. But the fact is, technically, we could do that now with this approval. And I think that's what Dr. Paul was driving at when he asked you the question. So we'd love to hear what Dr. Whaddya says about that. Because she can't say, oh, no, it's too early now, because it's actually been approved, but we don't know in practice what's going on. So we'll learn over the next 6 months. It's bound to come up.
Okay.
I mean, one reassuring takeaway from all of this talk is that you have options.
Absolutely. Yep. Sometimes too many options, but that's why I need to come to this call so you guys can help me filter all out. So
we should probably get on to our next new Gent.
Thank you very much.
You're welcome.
It was great information. Thank you.
Thomas Matika still has a question.
Yeah.
Yes. When you're talking about baseline testosterone test, what qualifies as a baseline testosterone test in terms of when you received it? I don't know why you would have received it, but is 10 years ago before your diagnosis? Does that qualify? Does it have to be uptight, closer to your diagnosis? Could you comment, please?
Sure. I mean, testosterone declines over time, so a 10-year-old test would not be appropriate. It would be as close as possible to the start of ADT. The reason you would want it is to know how fast you can expect. I mean, Rick may have additional reasons. One reason that I would want to know it is to know would be to get an idea how quickly I might recover. You know, if it was only 300 at its highest, then you would not expect to go above 300 in recovery. Also, if it's low, it may. If it was low, it may recover more slowly, I think. Rick, are there other reasons to get a baseline?
No. I mean, those are the main reasons. I think you covered it really well, Ben.
Thank you.
Okay, thank you very much.
You're welcome, Thomas. Okay, Mike Doherty. It is your turn to be the newbie. You've told us your name, Mike Doherty, Docherty. How old are you, Mike?
Sorry, and apologies for not filling out the questionnaire. I signed up for this and I had it in my calendar, and I got the reminder just before the meeting, so I never filled out the questionnaire. So I'm sorry for that.
Oh no, we don't typically send out a questionnaire. That was a nice add-on from Jim.
Okay.
So you don't have to feel bad.
All right. Well, you set the bar high, Bill. So, I'll try to give you kind of just the basic backstory. So I'm 16.
No. We'll walk you through it.
All right. Oh, that's right. You're going to
We'll ask a question, as they say in private eye shows. Where do you live?
Boca Raton, Florida, but I'm in the process of moving to Charlotte, North Carolina. Good timing, huh?
Did I ask you your age?
I'm 69.
And are you a veteran?
No, I'm not.
How did you learn about AnCan?
I think through a combination of just internet research and specifically PCRI.
And so how were you diagnosed, and what kind of
Well, I had been on testosterone therapy for years, probably 15 years, and was getting my PSA checked every 6 months. It had been climbing from the 2s to the 3s very slowly, but in a 6-month period, it went from 3.5 to 5.1. We did a retest, and a few weeks later, and it was 5.2. So that's what drove the initial MRI.
And you had a biopsy?
Yeah, so the MRI came back with a pyrite 4 and 5. The biopsy was 12 cores. The initial read from the pathologist was 4 of them cancerous with Gleason scores of 6, 6, 7, and 8. There was a second reading by Johns Hopkins. My urologist asked for that, really because he didn't believe that was an 8, because he was hoping that maybe it was overrated, but it turned out Johns Hopkins confirmed the 8, but they also identified something missed on the first pathology read, which was that I've got cribriform subtype. At that point, I did do a PSMA PET scan that came up clean in terms of being local to the prostate. But as I dug into the research and the articles and papers on cribriform, I guess I lowered my confidence that it really was contained, because it sounds like cribriform is a much more invasive subtype.
Yes. Yeah, you're on the money. Yeah, even Gleason 6s with cribriform are suspicious.
Yeah, and I don't want to jump into get ahead of myself here, but the one thing that's been kind of interesting and frustrating about this, I'm an engineer, so I'm big in researching, and so I didn't mind doing some digging, and I did a consult with Vipul's Patel and Celebration, a surgeon. I did a consult with the local Cleveland Clinic on radiation. And then I did a multimodality clinic with a cross-functional group at Lynn Cancer Center. And with my move, I also have a scheduled review with Dr. Burgess at Atrium Health in Charlotte coming up next week. What's been interesting for me is I fairly quickly came to the conclusion, before I knew about the cribriform, that I was going to go the surgery route based on my urologist's recommendation and what I had read, that it was early. I was young enough to handle the surgery, and I wouldn't like the ADT very much. So the initial voices I heard were pretty strongly for surgery. When I read about cribriform, those voices those professionals still were generally recommending surgery, but I really was questioning whether maybe I should be looking at radiation and ADT, which is what drove my second and third opinions. Unfortunately, when I did the multimodality clinic at Lynn, it was medical oncologist, head of surgery, a radiation oncologist, and they're supposed to come in with a recommendation, and the recommendation was I could go either way. And then the surgeon and the medical oncologist continued to push surgery, and the radiation oncologist continued to push radiation. So I made the decision about a week ago, based on that last bit of information. I'm going to go the surgery route. I initially had set up this meeting in Charlotte to help me decide, but I've decided to pull the surgery ahead because I'm moving. We literally have to be out of our house by the end of September. And if I was going to do the surgery, I need to do it now. But I've kept the Charlotte appointment because I look at it as now that I'm going the surgery route tentatively, I want to make sure I've got the team in place for follow-on, because I think it's potential that I'll be part of that 30 to 40% of people that get the prostatectomy that need adjuvant therapy. So I'm somewhat prepared for that.
Rick, you had input?
Oh, I have a few things. Why don't you sort of finish the questionnaire? I put my hand up so I didn't, just to make notes, but finish off the questionnaire and then I'm making notes here.
So, okay, you may have mentioned this in passing, so, and I apologize for missing
It's okay.
it. So your main care is or is going to be at what institution and with what doctors?
Well, my surgery will be with Advent Health in Celebration, Florida, near Orlando. But my planned follow-up, but I've not set this up yet. I'm in the process of setting it up. Would be with Atrium Health in Charlotte at the Levine Cancer Center. Because I'm going to be out of my house by the end of September, so it made more sense to just put the pieces in place in Charlotte. We thought.
Did any of the teams recommend that you act quickly?
My urologist did from the beginning, especially when we found out it was crib reform. But I am on bicalutamide 50 milligrams. When I met with Patel, he put me on that, and Cleveland Clinic, my urologist, and Advent Health all felt well that being on that I bought myself another, at least another couple of months, but I don't need to overextend this.
On the other hand, you want to get a quality prostatectomy.
For sure. And I'm frankly, I'm very comfortable with Dr. Patel and his record and their approach. So if I go the surgery right, I feel good about that choice. But I guess until I get to a week of the surgery, I won't call it a final decision. But that's definitely the direction I'm leaning.
Jeff Markey, you have input?
Yeah, a couple things. Are you getting nerve sparing?
Yes, it is nerve sparing.
All right. Do they do Retzius sparing robot assisted surgery? It's RETZIUS, which is supposed to spare both your urinary function and your erectile function. It is a newer type of prostate cancer surgery that a lot of people are getting involved with. UCSF does it. There are a number of sites that do it, but you might want to ask. That is
that is something that's not come up. So could you repeat that for me?
It's RETZIUS, sparing. It's robotic.
Put it in the chat window, please, Jeff Markey.
Okay.
Put it in the chat window.
Great.
It is robotic assistant. I've heard from a number of guys who've had it done, and they get their incontinence back quickly, and it's supposed to help for ED as well.
Okay. So great. I will definitely look into that. And it certainly is robotic assisted, and he's got a high volume practice, but I will look into the RANCIS. Thank you.
All right. So I have a few things for you, Mike, and you may not want to hear them.
I want. That's why I'm here.
Okay. First question is was the crib reform large or small crib reform?
Unfortunately, large.
Large. Okay.
Yeah.
What surgery?
Have you run the MSKCC nomogram?
I have.
And what was the likelihood on that you're you were going to have progression free?
Well, unfortunately, at least the nomogram I did not account for crib reform. I don't think they have one that accounts for it.
Correct.
It's a post RARP nomogram, but I remember it being 10 plus years, but I don't remember the exact number.
Okay, well, take a look at that again. I'd really recommend you do. It doesn't account for crib reform because really we've only been talking crib reform since about 2017, 2018. Not that it wasn't there before, But that's when Dr. Epstein first noticed it, or
Right.
noted it, and
Right.
recorded it. And so we look now, and it's a failing with the MSKCC, but it's still a very, very good guide.
Yeah.
And my concern is that in your case, I think your 40% is probably an underestimate. I think you're probably going to be over 60%. I can't say for sure. Your PSA was pretty low. I don't know the bulk, but I'm just guessing. So
Because of the crib reform.
well, I think it'll be 60%. I think it'll be 60% on MSKCC, and then probably you have to layer the crib reform just from your own gut over that. So
maybe I'm sorry. Maybe I didn't do the same nomogram you're talking about. The only one I saw was one that was related to a post-radical prostatectomy.
That's right.
Yeah.
Well, it is a pre that they have two. They have a post-radical one and a pre. So that
I
you
took
can
the
do
post, so
okay.
I will take the pre.
You need to take the pre, and I put a link to the pre in the chat window. By the way, guys, you can download that chat window. The 3 vertical dots next to the push pin allow you to download it. You can also just click on the link that I posted, and it'll open in your browser, and you can look at it later. But I think you need, if it were me, I did do it, and I made my decision based on it. And I was a lot younger than you at that time, and I had a 70% chance of recurrence, and I didn't want to roll the dice for 30% because I said, look, if I'm going to have to do hormone therapy and radiation anyway, why do I want to add another set? So that's the first thing. I want to go fairly quickly because we're getting late here. The second thing is we're not fans of Patel. He's got a factory there. He's a great salesman. He comes in and talks the head off, but the likelihood that he's going to do that surgery is very, very small. He's got about 3 surgeries going on, or 4. We've heard the number at any one time, and I wouldn't go there. But that's your decision. I would be encouraging you to talk to other docs. Secondly, I wouldn't go to Atrium. We're not fans of Levine for a whole number of reasons where we haven't seen great treatment. Also, we don't he's not there any longer, but the guy that used to run Levine is not high on our hit list. What we are doing with most of our guys coming into the Charlotte area is sending them up to Duke.
That was my other potential.
Okay, so we have a great relationship at Duke. We can get you. We can make introductions for you to Dr. Mao, who is the head of the department of the urological oncology, the surgeons, and the other person we know really, really well, and she is great, and she gets very good marks from anybody we send to her is Deborah Kay, who's also a urologic oncologist. I'd love for you to sit down with one of them before you make a decision and work it out with them, because they're both the type of docs that are going to tell you what is best for you. And then if you're going to go through radiation, if you choose to go through radiation, there are different ways to go. You're probably eligible. I don't know, but you're probably eligible for SBRT. So you wouldn't be looking at 20 to 40 treatments. Or you might, I shouldn't say that. You could replace 20 treatments with 4 or 5 treatments, but you might still be eligible for the boost across the pelvic girdle, depending on other results. But if it were me and I was moving, the other thing is we can give you much better docs, we think, in South Florida as well, that are associated with Sylvester.
Yeah.
But you know, I don't want to put too much of a spanner in the works, a wrench in the works. And we've got some Florida people who are on this call right now. But Mike, that's what I would be doing. And I would say, if you're on bicalutamide right now, I mean, it's kind of weird that Patel put you on bicalutamide, but he did. It's not that strong a drug, but it'll buy you the time you need. I would move back up to Charlotte and I would work it out. The other thing is, I wouldn't want to be getting a surgery today and thinking that you're going to be okay to handle a house relocation at the end of September, because you could be. It's not impossible, but I would say the number of guys we see going through surgery who can do that is probably less than 30%. You know, a lot of these guys are really dealing with stuff, and you're going to finish up giving yourself a hernia. And we see a lot of guys who give themselves hernias in this group as well, I want to tell you. So I would say, take it in your stride, stay on the bicalutamide for the time being, and then reset when you get to Charlotte and get your care at Duke.
Well, I really do appreciate the fresh point of view. I do. As much as that may be a wrench in the works, it's the first negative things I've heard about Patel, but I can certainly understand the factory viewpoint of it. One other thing I'd like to ask, and I'm on my phone, so I don't know that I can download the links. I'm hopeful that I can get some of these links in the recording. Is that possible, or?
Yeah, we post all of these links will be posted in the recording.
Okay. And if I could ask a follow-up question as a general rule, because I think I was much more leaning toward trying to do the radiation and ADT as I read about grid reform. But honestly, most of the professionals I talked to, and maybe in hindsight it's because I talked to the wrong professionals, were still putting me toward the surgery. And one of the reasons was because that I would find the hormone therapy extremely difficult for 2 years.
Yeah, but that's not the point. I mean, we'll work with everybody on this call that you're looking at has done a lot of hormone therapy. Maybe some people have done 6 months. Most people have done more. We've all done it, and you can handle it. Here's what my concern is. There was a recent reference. I've got it. I'll find it. If not now, I'll find it later. But there was a reference about
Protect study?
Yes, the Protect study.
Yeah, I read it. I read it was one of my first papers, and my life expectancy is about half of the traditional approach. That's
right. And so you see the rate of recurrence with surgery is way higher with crib reform than with radiation.
And what baffled me was that everyone I talked to said that the reason they would support radiation was because of the high risk for grade 4+4, not because of the crib reform. And basically I was told I'm thinking about it wrong if I consider the crib reform in that.
Well, no, it's because crib reform is new to a lot of these guys. It isn't in their thinking, and they don't even look for it. And they don't, and you know, somebody like in Patel's office, they'll send it off, it'll come back, they send it to a local guy. The local guy doesn't even bother to note crib reform, as like happened with you. They don't know about crib reform, and they don't keep the records on crib reform. But we've done the studies. That's what the Protect was all about.
Yeah.
And that's all we're trying to do. I'm very wary of the clock here. Len, welcome. Glad you got back. Anything you want to say about Patel? I mean, I know that you when you're in Florida, you're on the other side, but we know a bunch of guys who have looked at Patel, been through Patel, etc. Any input on Patel?
Patel in Florida? I don't know.
Celebration.
No, don't know anything about him.
Okay. Anybody else have anything to say about Patel? I won't pick on Dr. Paul. I will not pick on Dr. Paul on this one. He can volunteer. He can always volunteer. I won't pick on him.
Yeah, well, I will volunteer by saying time is on your side. So the rush to get something done, I think, need not be in your forefront. And as a surgeon myself, I will say that the responsibility of the surgeon to his patient, whether it's conscious or subconscious, is much greater if he has done the surgery. So I would feel more comfortable you having the surgery where you will be followed by the person or the institution that took you on as a patient to do it. I mean, it's a bit of a, I'll say, emotional circumstance, but since your time is on your side and you're moving, that would be my kind of playing field advice.
Right. And we should add Mike, these words come from a very, very well-respected sage doctor who was once president of the AUA. So, you know, who's posting huge things in the Alfredo, I can't get all this stuff onto the chat. When we post it, I'm limited in my number of words.
Okay, it's for the people.
This will all get carved up in the chat.
I'll stop. It was for people to look at later. I'll stop.
Okay. Don Rogers, what did you have something to say about Patel?
I consulted with Patel 4.5 years ago, and the first question I asked him, if I have you do the surgery, are you going to do it and not one of your other doctors? And he assured me he was going to do all the cutting himself of the prostate. The opening and the closing would be done by the fellows, but he assured me that it was going to be all his work. Mike, I live in Boca Raton. I'll give you my phone number. Please give me a call tomorrow. I think I can help you out too.
Great, thank you so much.
Great. And Don Rogers is very familiar, by the way, with the urological oncologist that we like in who's in South Florida. I just forget where he is right now. It's just gone out of my mind for a second.
Yep.
But he's very familiar. You know, my only problem with that, with what Don says, is that we know that he's got 3 surgeries all going on at exactly the same time. So you have to
make the same
make
question and got the same answer Don did. I will say that.
Yeah, and I think that's the answer everybody gets.
Yeah.
But you know, we've also heard from other people that that hasn't been the case. So I don't know. You have to judge. I'm just telling you, just reporting. We got to move on, Ben. Let's get into our questions, and then we can come back to this at the end later.
Thank you. Thank you very much.
Yeah, Mike, I think you got your money's worth.
I sure did.
Oh, Mike, do we have your email address, or you can put it in the chat window, because we will want to send you reminders.
I'll put it in the chat.
Okay, thank you.
Pardon me while I go off camera to do that.
Thank you.
Okay. Bill Lawler, you expressed interest in speaking.
Yes, just an update from last week. Last week, I reported that I was tolerating the Orgovyx and the Nubeca fairly well, and that this past week I was having the spatial ore installed and the fiducials, getting ready for the IMRT to start in a couple of weeks, and in mid-September I'll have the CT/MRI lineup rehearsals for the procedures. And last week they did a blood draw on me, and my PSA, which was above 12, has dropped to 1.18. And
very nice.
I'm not quite sure I understand I mean, obviously it's way the hell down there, which is fantastic, but what is the interpretation of that?
You want to feel that?
Yes.
Yeah.
Go ahead, Ben.
Oh, wait, Jim had his thumb up. Did you want to talk?
Oh, no, no.
Oh.
Good news. Good news. The drugs are working.
Yeah, the simple interpretation might be the right one, that the drugs are doing what they're intended to do.
So, do we think that the tumor the tumor is shrinking, or the gland is shrinking?
I mean, it's hard to say what exactly is happening in the absence of a scan. That's why they do scans.
Okay.
I think the way I might answer it to sort of satisfy your question is that your testosterone has also probably dropped to a very low level. I don't know if they measured your testosterone or not, Bill.
They didn't. That wasn't in this mix.
No, they do sometimes. They don't in other. They don't at other times. But I think that's what's happened now. When the testosterone isn't in your body, the cancer doesn't have anything to feed on, and when it doesn't have anything to feed on, not just the cancer, the prostate cells too, the healthy prostate cells, they die off because we're starving them. And when they die off, we hope we see maybe a reduction in the size of the prostate, and we see a reduction in the size of the tumor. So that's why hormone therapy works. So by reducing the testosterone, we're starving the prostate cells, and we hope we're not training him into doing something different. And up front is when you get your biggest bang for the buck, and that's what we're seeing.
So corporate 101 is not to correct your boss in public, but the feeding testosterone, this testosterone feeding the cancer story is a little misleading. It doesn't really work that way. It's not really starving it. It's preventing the process that causes cancer. It's actually a sort of a complicated process, and that's why you rarely see good explanations of it. Yeah, it's not as simple as depriving it of food, but the end product is, as Rick said, is that the tumors will shrink.
Great news. Great news. And I also wanted to, throw in the praises for Dr. Paul and Matt Cooperberg, and the two British guys who did that seminar last week on the TE2 patch, which was nice to hear. I just want to know when it's going to come to this country.
Dr. Paul?
Very soon, I hope, but very slowly as well. And the next big hurdle is waiting for the NCCN guideline, we'll say revision or update this fall to see where it stands in that very important guideline document for physicians.
Fantastic. I look forward to that opportunity.
As indeed too many of us. So are you good, Bill?
I'm good. Thank you very much, gentlemen. Always a pleasure. Thanks for all the great information.
Thank you, Bill. Al Latimer, are you back? Okay, we'll come back to him. Tony from Syracuse, it's your turn.
Yes, I have a question. The last time I was in the group here, I think it might have been last week, a comment was made that said once you're Gleason 9, essentially a cure is off the table. And so maybe I've been, naive and misinformed. But I'm in my 7th month here of taking Orgovyx, and planning on starting radiation in October, November, and not really looking forward to doing radiation because, side effects, discomfort and all. And I'm tolerating the Orgovyx quite well. And so part of the motivation of doing radiation is I thought there was a cure somewhere down, at the end of the road. So I guess my question, maybe it's a silly question, is does anyone ever consider doing the hormone deprivation indefinitely and not doing radiation? Is that a possibility?
Who would like to field that?
I'll take a stab at it, Ben.
Thanks, Ben.
Whose phone is that, Tony?
That's mine. I'm trying to stop it. All right.
Yeah, so sure, you could choose that option. It's the reason why it's not recommended is because eventually it is highly likely that you'll become resistant to the hormone therapy. And then once your cancer is what we call castrate resistant or hormone resistant, then it's a lot harder to treat. So that's why it's recommended that you take out the mothership in the prostate with radiation, surgery, however you want to do it. Tony, do you know if you have metastatic spread of your tumor?
Okay, I had surgery at the end of October, and I had 2 PSA scans that were both negative. One was last September, one was on New Year's Eve. So within the last year, they were both negative, showed nothing. So the prospect of radiation, doing radiation is going to be, the pelvic area without a definite target. I did have a seminal vesicle involvement. Yeah.
Did they remove the seminal vesicles when they did your prostatectomy?
They did not. They did not. The margins were completely negative, and the post-surgical pathology report indicated that there was seminal vesicle involvement, but no, they weren't removed, and no lymph nodes were removed.
Okay, I'm just curious, get an opinion from Dr. Paul. If someone's a Gleason 9 and they're going to do a prostatectomy, wouldn't they just routinely remove the seminal vesicles, or no?
Well, okay, I was Gleason 7 before surgery.
Oh, okay.
I was Gleason 7 and told that I was favorable intermediate. And actually, the radiation oncologist tried to talk me out of the surgery. And then the pathology report right after the surgery upgraded me to 9, and found even though the margins were clear, they found I ended up being PT3, I guess, and Gleason 9.
Yeah, can I just say, I don't know how they would know the seminal vesicles were involved if they didn't remove them, because removing the seminal vesicles currently is part and parcel of a radical prostatectomy. There's some experimental, I'll say, or early thoughts with regard to leaving them in very well-defined cases because erectile function may be better preserved if that's the case. But what you're saying doesn't compute. If they left the seminal vesicles behind, which is not the routine, why are they saying you have margin negative seminal vesicle positive specimen?
Yeah, I can't answer that question. I don't have the report in front of me. Yeah, I mean, that's what I remember from reading it. Yeah.
Rick? Oh, you're
muted, Rick.
I'd like to switch gears, but I would suggest taking a good look at that post-pathology report again, Tony, and also your surgical report. Just take another look at it and read through it again. I want to talk about this cure issue because it's one of my own pet topics. And my understanding and training, as much as you train as an advocate, is that I've always been told that there is no such thing as cure for a prostate cancer that has a Gleason 4 in it. And when doctors talk about cure in prostate cancer for somebody other than a 3+3 grade group 1 person, then we need to drill down on them, because in cases where I've seen that happen, they backtrack. So what we can do is we could refer to dare I say, a mentor of Dr. Paul, Dr. Snuffy Myers, who treated Dr. Paul many, many years ago. And he came up with a term which I use, which is a durable continuous remission. So in other words, we can get remission where we don't see an increase in our PSA. Our PSA is at a very low level, and that can go on for a long time. But we cannot say it will never come back. And we've had issues with a couple of men, Dr. Jack, who's on this call today, where his cancer came back after many years. My close buddy Dave, whose cancer came back after 17 years. And we don't believe that we should be using the word cure. It's tantamount to cure. But when I go in for my PSA test once a year and I'm 17 years out, there's always the possibility it's going to come back at more than less than 0.1. And any doctor who tells you otherwise, I think you need to challenge them.
Okay, I guess my concern was that, I'm going to go through the torture of radiation, some 35 or 40 treatments. And, if I get 17 years would be great. I'm 74. I'll take 17 years. That'd be great. I'll take 7 years. If I'm going to be back in this, if I'm going to go through that radiation and be back in the same boat in a year or two, why not just stay on Orgovyx the whole time? Because
we don't, Tony, we don't have a crystal ball.
Yeah.
We think it's going to be the best thing for you. We think it's going to give you a continuing remission, but it's not true. We can't assure you.
Right.
We can't. There's no guarantee. Your doctor, your radiation oncologist ain't going to give you a guarantee, a money back guarantee if your disease comes back. It just doesn't work like that. So we think, yes, we can treat you, otherwise we wouldn't be doing it, but you don't have any distant metastasis.
Right.
And we think that there's a very good chance that that we can nail your disease. Go ahead, whoever was
Wait. I just want a reality check. A lot of people on this call have gone through radiation. Has anybody regarded it as torture? People have had side effects.
Oh yes, thank you. I was going to say that. Thank you, Dan. Thank you. Yes.
I went through it. It wasn't torture. I think that's true in the majority of cases. People do sometimes get side effects.
This is what I was going to talk about.
Okay, go ahead.
I had surgery. 3.5 years later, my PSA hit 0.2. I had 40 sessions of SBRT radiation. I went to work immediately after each one of them. I never had any side effects or problems for 6 years when I started having some incontinence issues, but I'd had surgery and radiation. Radiation was just a non-entity. Yeah, one time I didn't have enough water in my bladder, so they had to hold off for half an hour. But it was a non-event. And the thing is, people who get the longer number of sessions, 35 or 40, have less radiation and it causes less side effects than those that get it in much shorter series of treatments.
Okay, well, thank you for that. That's good to hear.
Yeah, I mean, there's a lot of things that are indeterminate about this illness, and one of them is how badly you'll come out of any treatment that you get. But we could say that in many cases, people rarely want to talk about this as torture. Are really impelled to regard their radiation as the worst part of their treatment. Jim, your hand is up.
Yes. Let's see. Back in 2017, I started the doublet therapy, which at the time they said you will be on it the rest of your life. Well, after the 5 years, I stopped it totally, and I've been on a 4+ year treatment holiday ever since. Okay, and the PSA is 0.13 after 4+ years. So I did not do continuous ADT plus the last 9 years.
RJ, what say you?
Yeah, I wanted to address the radiation versus ADT, like 40 sessions or 5 sessions of SBRT, like a finite period of, radiation versus a lifetime of ADT. Like, there's some people that actually think that the ADT and years of being on ADT is much more of a torture than radiation. It all depends on perspective, I would say, but it's better to have that perspective influenced by experience. There's a lot of experience in this group, and so one thing is just to reach out and connect with people in the group and find out and get some different experiences on. There's some people that have had severe side effects from the radiation, but I would say it's not really torture. It all depends on your perspective. So it can be a walk in the park. It's not guaranteed, though. None of this stuff is guaranteed. Just like you may have remission for 20 years or maybe 2 years. It's hard to say.
Yeah, I appreciate that. The thing is, from my perspective, is that I'm tolerating Orgovyx very well. Just having a few hot flashes, a little bit more than usual fatigue, but that's about it. And so looking forward to the radiation is a little bit daunting, because I'm hearing about more compounded type of incontinence, and things called fistulas and all that sort of thing. So it's my perspective here is a lot of fear of the unknown going on right now, and I appreciate everybody's input.
Rick, would you suggest that Tony check in with Men Speaking Freely?
Oh, yes, definitely. Tony, have you joined Men Speaking Freely in the past?
I have not.
Definitely think you should, and I am making a note to make sure you get a reminder, because this would be a great issue. Dr. John isn't here. Dr. Jack, do you think this would be a good issue to talk about in Men Speaking Freely?
For sure, absolutely.
Okay, I will do that.
Okay, I'm writing it down to make sure we add you to the reminder. If nothing else, the reminders are worth reading.
Sure.
Okay. Thank you for thinking of that.
And thanks for your question, Tony.
Sure.
Tony Fig is next.
Good evening. I'm glad to see that Dr. Paul's sitting down, because I had a good meeting with my GU medical oncologist at Wilmot Cancer Center, and we were talking about hormone therapy, and we've talked about it a number of times, but he said he would not be adverse to using E2 as a monotherapy or in conjunction with hormone therapy. So I said, is there politics involved in it? He said they've been discussing it there. And one of the main issues was insurance wouldn't cover it if it's used off label. And because of the price of it, that really would be a non-issue. But I was really thrilled to hear him say that, they've talked about and considered it. And that's something that he would consider if I did need to go back on hormone therapy. So at last week, Dr. Pierre made an excellent suggestion to discuss with my doctor about doing a biopsy of auxiliary lymph nodes, because the Acumen scan did show an indication there. And so Dr. Garcia talked with the radiation oncologist that did the mapping for me for my salvage radiation. And he also talked with the radiation oncologist that did the salvage radiation treatment, and they discussed the various options that the scan had brought up. And one of the issues was that they didn't feel that a CT guided biopsy would be accurate enough so that it would not maybe cause lymphedema in the area. So he made the suggestion that we do an ultrasound initially to determine any other lymph nodes in close proximity to it, to the one that lit up. And then that's scheduled for 3 weeks out. So depending upon the ultrasound indications, then they may go ahead and do a biopsy of that area there. So I thought that was a good precaution on that part. I had a CHEK2 gene when I had my initial genetic testing done, and that raised a concern for me when the Acumen scan showed an indication by the anterior part of the rectal wall, and the two radiation oncologists and Dr. Garcia reviewed all of the pictures from the scan, and the urethra, it travels very, very close to that area of the rectal wall, and they were pretty much convinced that that was something that the urine picked up the radio tracer, and that it was not cancer in the rectal wall. And then they looked at the right obturator lymph node, and that had received during the pelvic girdle radiation treatment, salvage treatment, that it had previously received 50 Guy during the treatments. They thought that if they were to treat that, there really could be a higher risk of further damage. And that they tied that in with perhaps whether or not they would do anything with auxiliary node in the armpit area. And they thought that, you know, an evaluation, because these were all very, very small in size, borderline in size, they didn't feel that it was likely to provide a significant clinical benefit at this time. And they were, you know, worried about the radiation effects, especially with the lymphedema in the auxiliary area, and then in the abdominal area. So to sum it up, they wanted to, they thought it would be best just to continue to monitor the PSA and then do another Acumen test when the PSA rose maybe to about 1.5. So that
so Tony, I have a question for you.
Yeah.
How did they how can they justify it being local when you have that auxiliary lymph node involved?
They said that the radiologist, they were going to talk to the one that read the scan and did the report, and they thought that was an error.
Okay.
How that was stated.
How do you feel?
Oh,
go ahead,
sorry.
Ben.
Oh, just no. I was going to take another line of questionings. You want to go ahead, Rick?
Yeah, I just want to ask Tony how you feel about waiting, and what's the very latest PSA that you have?
0.62, and that's because my apparently my body's not producing PSMA. The thing about waiting that also came to mind is from my pathology report. I was a Gleason 9. I had cribriform, interductal, also seminal vessel, and extra prostatic extension and bladder neck invasion. And when they removed the prostate, they took out 31 lymph nodes, but they were all negative. So with the aggressiveness of these other findings from the from the prostate pathology report, you know, it makes me wonder about not being concerned and just riding it out at this point.
You were ductal, right? Not intraductal?
Interductal, yes.
Interductal.
Yes.
Or rather ductal. Okay.
You know, it's a really tough one. Clearly, to us anyway, you have a variant type of prostate cancer. It doesn't behave like most people's prostate cancer. At the same time, you've gone quite a long way, and thank God we don't see any terrible things.
Right.
And so we, you know, this is what we're balancing. I mean, we can't tell you what the outcome would be. We can empathize with you with the anxiety that it creates. We all get it, and we love you, Tony Fig, you know that. And we want the best for you. But you do have an unusual type of prostate cancer. Probably the very best thing that can be said and can be done in all of this is if you're nervous, you got to go get another opinion. I mean, drive over to Dana-Farber, which is probably the closest to you, and go see our buddy Dr. Atish, who Bill Lawler's seeing right now, and see what he thinks. If we can't help you closer. We don't think there's somebody. We don't have the right person for you in Buffalo at Roswell Park. So it's going to be a trip somewhere. The closest is probably Boston. We've got 3 or 4 different people. Atish, what's his name with a P? I'm forgetting his name, but we've got a bunch of different people we could send you to at Dana-Farber. Maybe that's what you've got to do. And people who really understand variant disease, which they do at Dana-Farber.
I'm not adverse to traveling. When I was doing naturopath approach for the prostate cancer initially, I was flying to Tulsa and Boston, so I'm not adverse to doing that.
All right. Well, I probably would send you to Atish. I mean, we know several of them, but I like Atish very much, and he's just so kind, and he's so smart. And I'll make a note and I'll send you and call and try and get an appointment. And if they mess you around, and I'll give you an alternate name as well when I send it to you. And thank you, Bill. I'll give you an alternate name and get a second opinion on where you are right now.
Okay. And
Anybody else?
How the ultrasound comes out with the lymph nodes.
Yeah. Anybody else have any other thoughts for Tony?
So I'm sorry, Tony. Did you say that they can't biopsy the lymph nodes?
The auxiliary lymph nodes, they said that there's a lot of risk with getting lymphedema from doing the biopsy in that area. So we're going to look at the ultrasound to see the number of lymph nodes in that area there and determine what to do to get a biopsy.
I mean, if you have a cancer that's not showing up on a PSMA scan and your PSA is low, to me, it's time to think zebras. And I would go to. I'm surprised you didn't mention Misha Beltran, Rick.
Oh yes, thank you. Yes, Misha Beltran. I was going to look at my list, but I was going to look at my list before I would. Misha Beltran would be great. Would be another great person to talk to. Absolutely, Ben.
Ben, that was an Acumen test that I just had.
Yes. So it showed up on the Acumen and it did not show up on the PSMA test. And that's exactly.
I had a PSMA in February and it didn't show up.
That's exactly the kind of discordance that raises concern.
Yeah. I'll send you Misha's. Misha knows as well. Atish knows as well. And you can say you're referred by us. When if you write to Misha, you can say Ben referred you and I referred you because Ben's seen her before. But they know us really. Atish knows us really, really well. If we've already got too many GU medoncs on our advisory board, otherwise I definitely would have asked Atish to be on our advisory board. That's how highly we think of him.
All right, I appreciate that information.
I do want to make a quick. If I may, Ben, I do want to make a quick reminder announcement. Next week's meeting is going to be on Tuesday. Okay? Next week's meeting is going to be on Tuesday. The date will be the 2nd. Well, no, the date will be the 1st of September. The date will be the 1st. And that's because next month is a witching month. And the first Monday and the second Tuesday are on consecutive nights. Now, we know you love us, but we don't think you love us that much that you want to come to meetings on 2 consecutive nights. So we have to make a switch. And I don't want anybody to forget, and anyone who's listening on the recordings, the Tuesday meeting will be next month in September, will be September 1st and September 15th. The Monday meetings will be on the regular dates. The only downside is we have to clear out the room promptly because the care partners are going to come in at 8 o'clock Eastern, etc., etc. So please note, next week we will have a meeting and it will be on Tuesday.
Lola, it will be at the Tuesday time.
And it'll be at the Tuesday time. Yes. Thank you.
Excuse me, Rick. And then immediately followed by the veteran support group at
Yes, immediately followed by the veteran support group too.
Yes.
Now they
in a different room, though.
In a different room. They don't impinge on us. Them vets give us space. And poor old Jim Marshall is in for a marathon. He's going to be sprinting out of our group to the bathroom, and then he'll be back to open the room for the Schmier, to open the Schmier room. So just some housekeeping, Ben, that I thought we should get in.
Yes. Yes. Good idea. Dr. Pierre, your hand is up. Oh, you're not muted, but we don't hear you.
Go to the gear in the upper right and change your mic.
Okay. Looks like we have a...
Can you hear me now?
Yes, we can hear you now.
Okay, I just wanted to mention to Tony that when I scheduled to see Dr. Atish, it took 3 or 4 weeks to get me in. So while he's waiting for the ultrasound, he probably should look into it. And that way both things can happen within a few weeks.
Okay. Okay.
You good, Tony?
Did we lose Tony? All right. I think we might have lost Tony. Okay, let's move right along because we're getting up to the top of the hour here and we still got a few people left.
A few. Yes. Yes, Al Latimer, we've been waiting for you. We held a spot for you. Al, are you there? Al
Okay,
Latimer?
yes, now I'm here.
Good.
Sorry,
Okay.
sorry, a contractor showed up I had to deal with. Anyway, got that resolved. So Rick already knows what my question is. That I've been using estradiol for a long time, but I've been running into a problem with it lately when I sign up for clinical trials and they don't want me on estrogen. I had one that rejected me altogether, but this one just says I've got to get back on traditional ADT. So my oncologist, Dr. Belusik, was recommending that, I'm sorry, I'm trying to get back get back to the oncologist recommending that I use Relugolix. Is that how you say it? Relugolix.
Mm-hmm.
Yeah.
And until I found out that my copay was $750, and so now I'm going to be doing Eligard instead. And Rick, you were telling me that that's not a good choice. So anyway, that's kind of where I stand.
Well, it's not that it's not a good choice, but if it
Not the
were
best choice,
me,
maybe the wrong word, a better choice.
if it were me, I'd prefer to go on Orgovyx, but you know, not everybody, as Ben said, I seem to have a preference, and that's only because I see that the guys, when they move from Orgovyx and off Orgovyx, they do better. But you've been on treatment so long, it may not make a difference. But again, you know, everybody should congratulate Al on the fact that he's in the VIR 5500 trial, which is this absolutely remarkable bispecific trial that Johan de Bono brought to the floor in the February GU ASCO 26, where we saw some just remarkable results from people who had been heavily treated with a lot of metastases. And it is being trialed here, and we have two people from AnCan who are in that trial, Al and Frank Chambra. So, you know, it's not 100% usual situation in your case, Al, because you've been on and off ADT and E2 for so long. But if I had my druthers and I could afford it, and I'm also surprised you haven't sort of burnt through the $2,100 yet. But if you haven't, I don't know.
I'm actually not even close to it.
Okay. Well, that, you know, I would say they're both going to have the same effect. I just think that the Orgovyx or Relugolix, that for those of you who aren't familiar, Relugolix is the generic name for Orgovyx, is going to be easy on you. But let me throw that out to my other moderators and anybody else who wants to comment.
Let me say one other thing. My testosterone is already under 2.5. So I've heard that a lot of the symptoms from these ADTs is when your testosterone is dropping rapidly. Well, my testosterone is not going to drop at all. Matter of fact, it might not even come back. My testosterone's been basically undetectable for God knows how long, 20 years, a long time. More than that, probably. So maybe the side effects won't be quite as severe. But they want me on something, and they don't want me on estradiol. I had asked them about that early when I was getting involved in this, and they didn't think it was going to be a problem. And then last night, the doctor called me and said, "Well, yes, it is a problem. If you want to be in this trial, you've got to get off estradiol." So I'm doing it.
Yeah, if it were me, I would stick my arm out or my butt out or whatever they put the estradiol in and never look back. But we have hands up. Well, worthy opinions in mind. Jim Marshall.
What about Firmagon? Is it an option?
I don't really know. I haven't had an ADT issue so long. I don't even know what the options are. I mean, my doctor, Dr. Blusick, thought that the Eligard would be appropriate, and so I'm just kind of at the moment I'm just going with the flow on that unless something else comes up. I don't think they're particular about which one it is, as long as I'm on something that meets the standards of the trial.
I don't know the side effects of it because I haven't been on it. I was on Lupron Eligard. So anybody been on Firmagon and can comment, please?
Yeah, I don't think that they're any different. I mean, it's the stopping of the testosterone that is causing the side effects. But there are minor differences. The Firmagon, people have issues with the shot in the belly, and that can lead to some problems. The Lupron, people have issues with the shot in the bum. I mean, that can lead to some problems. That's why the pill is easy to take. But I don't think that there's anything significant. The only thing is that if you got heart issues, you're maybe a little bit better off on the antagonist than you are on the agonist. But I would trust Belusic. If the benefit of the Orgovyx is that it's just so much easier to take. That's the big benefit.
Well, all things being equal, I would vote for that too. But this trial requires that I be up there every week for several months, and
Okay.
I'm going to be drowning in travel costs one way or another. And
Okay, so Jeff, do you anything quick, because we've still got about 4 people to go.
Yeah. There's Leuprolide, which is what you're talking about, has a plaque buildup problem. Even in the first year, it can build up plaque in your arteries. So that's why Firmagon might look better. If you took it for 3 months or got a 3-month shot of the Leuprolide, you could then on the first of the year, there's a $2,400 limit for all year on drugs next year. And you could live with it. I don't know. You could spread the payment out over the year.
well, that's actually a good point. And because now we're getting toward the end of the year, so if I started it now, I would have, I don't know. I think I still have almost I've got $1,800 to go on my to get to the maximum, and then I would be starting it all over again in a few months. So, but that's a good idea that maybe I switch in January.
Firmagon doesn't have that problem with the plaque buildup, but it's just something to consider.
Okay.
Rick, what's the name of that foundation that helps people with travel costs for trials? The West Coast Foundation that we were talking with.
Lazarus Foundation.
And does Al? Do you know about that?
I do not.
Okay. Check the. I can probably have it, but you can check Lazarus Foundation. That there may be some trial money. There may be money there for you, and I'll put it in the chat window. We just signed a letter to Congress this week, AnCan Foundation, which would legislate for better support for travel expenses for people wanting to attend trials.
Yeah, in fact, my wife is an AT&T retiree, and we actually have a catastrophic plan for this type of thing, but they require that you have 5 consecutive days of treatment, and this is only 2. I'm still trying to work around it, but I don't see that much. Don't see that much hope for it. But we've been pursuing that avenue too without success. But I did not know about Lazarus. I definitely will look into that. I know there's
it's Lazarex Foundation.
Lazarex. Okay.
And I'm just about to put it into in the chat window.
Okay. Well, that's a great tip. I did not know about that.
There you go. That's why Ben's leading this and not me. He's twice. He's got me. He's going for the hat trick now. Go on, Ben. Let's move on.
Okay. Well, thank you, guys.
Thank you, Al. RJ, it's your turn.
Okay, I'll be quick. I hope. So my quick update is that, and I told a little bit of my story, but I finished up chemo at the end of March, and I will say the recovery from the chemo took me quite a while. What took me was actually the muscle that I lost. So it's a combination of the chemo, and I didn't have the energy to do stuff. And then I got myself on the elliptical, but that only exercises certain muscles. So anyway, my medical oncologist sent me to a physical therapist. And so like I actually got all these exercises, and she said, you need to walk, actually. That's like the most important thing, because when I went in, I didn't have the right balance because I had lost these muscles. And then with the ADT, the problem is I don't actually get the muscles back very quickly. So it's a double whammy there that I've been kind of struggling with. But I'm feeling much better now. And also, this morning I took my loading dose of Orgovyx. So I went in. So I just, every time I go see the medical oncologist, I make sure that I'm in the holiday track. And so I got the Orgovyx. And then good news is I went to the pharmacy and I had a zero copay because I hit my limit for this year with all the other stuff I've done. And I was expecting like a $200-300 copay. So I actually hit my limit, so I don't have to pay for that until January. So good news there. That's my update. Thanks.
Thank you.
So anything you need to know from us? I mean, the highlight of all of that, Mr. RJ, is that one, we got you walking again, which is a good thing. Very pleased to hear that. And two, you hit your limit. Anything else you want from us?
No, I'll just keep showing up, and I feel well informed with this group, so thank you. And then I also I don't always wear my t-shirt, my AnCan t-shirt, but I'm always an advocate when I go in and I meet with the doctor, I meet with the physical therapist, I meet with my primary care guy. Like my next discussion is around statin. This ADT is like raised my cholesterol through the roof, and so like I'm not eating any saturated fat now, so that kind of sucks, but it is what it is.
So I just want to say before we move on, a quick shout out to RJ, who's been a fantastic supporter for us. And the good news, at least for us, is that RJ has retired and he's going to be helping us with a major project, and we're truly grateful. Major project on the technical side. Thank you, RJ.
Thank you. Yeah, it's been a very busy summer, but now I'm retired. I'm able to walk again. I moved over, for those familiar with the Seattle area, to Vashon Island in the Puget Sound. And so in my retirement, one of the things is I just look out the window at the water. It's awesome. I love it. It's like Bob Schwartz's picture there.
Right. And you swim, and now you swim to your appointments, right?
Yeah, of course. Actually, they have a water taxi, so I take the water taxi and I ride my bike. That's the other thing, is I've been riding my bike, and physical therapist said, yeah, that's really good. Just don't fall off.
I think you have to come up with a new bike, a water bike, where you can ride your bike into the water, keep pedaling, and you'll get the other side, and you come straight out the other end, and you keep it like an amphibious bike.
Yeah, I'll bring that up to Gemini and see what we can cook up.
Okay.
Okay, Dan in Schenectady, it is your turn.
Just a quick update. I got the Orgovyx. I started that last week, Thursday. And the only thing is that the hot flashes are different. And I'm looking for words to explain it, but they're different hot flashes, you know, but that's the only thing that I have experienced. In the biopsy, it turns out it's going to be a tissue biopsy and not a bone biopsy. And everything that they were sending me said bone biopsy. So, and they'll do that. It comes back in about 5 to 7 days. So I'm happy about that. And I was talking to the doctor about the darolutamide, and they said that I should hold off the darolutamide because if they test my PSA before I start the Pluvicto and it has gone down, then they're wondering why I'm there for the administration of the Pluvicto. And so it looks like I'm holding off on that, and I'm hoping that I'll be able to start the Pluvicto after I'll start the darolutamide after Pluvicto.
And the Albany Med update.
Oh yeah. And I had the Albany Med that they're doing the Pluvicto, and I have a consultation with them on the 3rd.
Okay. Okay. I mean, I get it. And it makes sense. I mean, you could have a great response to the Darrow, and then it's going to throw another wrench in the works. That wrench is getting thrown around a lot today, and it could get thrown into your works, and we don't want that. I haven't heard of before different type of hot flashes between the different ADTs, but I don't know how to respond to that one, Mr. Moore.
Well, yeah, I'll just mention it. They actually feel different, and I'm trying to find a word to describe how they feel, how different they feel, but I know they're different, you know. But I was just
Anyone else have experience switching from their ADT from a shot to a pill and having a different type of hot flash? Maybe one feels like you're in a sauna, and the other one feels like you got plugged into the light socket. I don't know. Anybody? I don't know, Dan. I don't. You've lost us on that one. Ben, what do you think about that one? That was a good comment.
I tried to write a poem once. I'm still trying to write a poem about how good it feels to get under a fan when you have a hot flash. And I just realized that it's very hard to find words for a hot flash. So I sympathize. Tony, what say you from Syracuse?
Yes, I've only been on Orgovyx, but years ago I used to take niaspan for high cholesterol, and the hot flashes involved with niaspan involved what happened was my whole body would turn beet red, and I would feel like I was on fire. But the hot flashes, I describe hot flashes with Orgovyx as being minor, and what happens is I feel like I'm a little overdressed for a few minutes, and that's it. So that's my 2 cents on that subject.
Thanks, Tony. This is everybody's favorite subject. The cold board is lighting up. Bruce C.
Yeah, I recently switched to Orgovyx too, and I've noticed different hot flashes. They seem to be more intense and more sweaty. That's the way I would put it. I seem to sweat more, but it's not a very short period of time. But they seem to be more intense since making the switch.
Oh.
Well, you know, we can always suggest, since we have the innovator right here in the center of our group right now, we can always suggest the Bob Alvord evaporative cooler. Which we are big fans of. Now, I don't know if you know about the Bob Alvord evaporative cooler. Do you, Bruce? Bruce C?
No, I don't.
Oh, you
Nope, I
don't?
don't know what it is.
Okay, well,
No.
it would be remiss of me if I didn't ask Bob Alvord to explain the personal evaporative cooler. Go ahead, Bob.
Okay. It's very important to have a very good, large cooling towel you can get from Sporting Goods or Walmart. It has to be drenched. Has to be drenched in water. And then you get a high quality, and what I have is a high quality neck fan. It's got four fans, one on the bottom, one on the bottom, one on the top, on each side. Can't even feel it. Maybe the most complaint is the noise. You hear a whirring noise, but I always keep my TV loud. And when I'm doing my couple of miles of walking every day with the dog, I have my headphones listening to my Pandora. But I measured the towel, and it's about 65 degrees, and it has to go over the fan so that the wind blows through the wet towel, and it maintains about a 65-degree skin temperature. And you got to water it a couple of days because with the air blowing through, it will evaporate and it'll get all dry and stiff on you. So, but that, and what really makes it all beautiful is I'm sitting right in front of a circulating fan right now. It's 77 degrees in my house, but it feels 72. I get hot flashes. I just switched from apalutamide to darolutamide. Thank you, Rick and Ben and Len and everybody for showing me the direction to go. But the hot flashes are still there, but they're different. You know, we're talking hot flashes. But this carries me through my 45 minutes of exercise in the morning, takes me through walking the dog, and I just finished a half hour on my elliptical, you can see in the back. You know, I exercise an hour and a half to 2 hours every single day. So this really helps. I can touch it right now, and it's freezing. So that's what I do. Can't say that it works for everybody, but you know, I kind of look at it as an engineer. So you kind of have your carotid there, cooling system right there. It kind of circulates through a little bit. And if you really want to get cool, you put it on your head. I know it looks ridiculous, but you know, us bald guys would really appreciate it.
Well, thank you. Thank you very much. We are very fortunate to have the innovator of your personal evaporative cooler in our AnCan group. If you want to know more, I've just put a link up. Well, I'll put it again. I just sent that only to the organizers. No, I sent it to Len by mistake. There's a link to the blog post that we did with a fine picture of Bob Alvord demonstrating he's famous, and we hope it'll bring some relief to a few others of you.
And I hope to see all of you at PCRI. I signed up for that. I know I'm going to miss you, Rick. You're going to be in DC, from what I hear.
I think so, yeah.
So, but if anybody is going to be there, look me up.
Okay.
Okay. Thank you.
Ben, our last two people have deferred to next week. I've made a note. They'll get priority in the system in the questions next week. So
that would be.
we're done.
Let's
Actually, I don't know who it is. I think it's Dr. John. I'll send them to. I think Dr. John is going to lead next week. So
before throwing in the towel, let's make sure we're looking at the same people. So Robert deferred. So the two who have not are Julian and Gary P.
Oh, Barry B. No, Barry B.
No,
came
Gary
in late.
P.
Oh, Gary P. Oh my gosh.
Yeah, I'll defer. I really wanted to raise my question with when Dr. Paul and Dr. Jack were both on, and they've left. So I'll defer, please.
Okay. Well, you might get Dr. Jack. You might get Gary. Yeah. Okay. So thank you. Sorry about that, Gary. And I've added you to my list, and we'll make sure Dr. John knows. So, yes. Yep. Okay. Gary P. Gary P. Okay. Robert, Julian, and Gary P. have priority next week.
So we're glad of all the MDs on the call, but we also are glad of all the engineers.
Dr. Alfredo is still here.
Oh, Dr. Alfredo is still here. I don't know if Mike is still here. He may have left already, but we got another engineer in our midst with Mike, I see. So.
I just have to say, when I was in engineering school, I didn't know that I would go to medical school years later. So.
Oh, yeah. All right. You're playing both sides of the coin there, Dr. Alfredo, I can see.
Exactly.
Okay. All right. So don't forget, it's Tuesday next week. It's a 3:00 start on the East Coast, a 6:00 start on the West Coast, a 6:00 start on the East Coast. And I think Dr. John's going to be there. And Ben, just please note that the second Tuesday, the fourth Tuesday is the 15th. It's not really the fourth Tuesday.
Yeah, I've updated my calendar. I'll be there.
Okay. I bet Ben is Mr. Witchin month, except he dropped his responsibilities this time, and it caught us by surprise. But we got it.
That's right. With no Alexa, I got to get one of those hats. One of the switch hats.
Yes. Yeah.
We could wear it when we announce. Okay, it's great to see everybody again. Thank you for joining the call. We'll see you all on Tuesday.
Yeah.
Good meeting, Ben.
Thank you very much.
Well done, Ben. Good night, everybody.
Thank you, Ben. Good night.